This is a technique video for bridge-enhanced anterior cruciate ligament repair, or BEAR, using adjustable loop cortical suspensory femoral fixation. Via anterolateral and anteromedial portals adjacent to the patellar tendon, diagnostic arthroscopy is performed to confirm that there is sufficient ACL tissue attached to the tibia for repair. A far anteromedial portal is established, optimized for access to the femoral ACL footprint. Any necessary meniscal work is completed. A notchplasty is performed if needed to improve visualization of the ACL femoral footprint. A passport cannula is placed in the anteromedial portal to prevent tissue bridges. 1.3 millimeter suture tape is passed in Bunnell fashion from distal to proximal in the ACL stump. Using an ACL tibial drill guide, a 2.4 millimeter cannulated drill is drilled from the anteromedial proximal tibia to the anterior portion of the ACL tibial footprint. A nitinol loop is passed up the cannulation and brought out the anterolateral portal. The nitinol loop can be switched out for a stronger shell-link suture, such as a FiberLink. A spade-tipped bead pin is placed through the far anteromedial portal. With the knee in deep flexion, the pin is malleted to engage the tip in bone at the anterior portion of the ACL femoral footprint and then drilled out the anterolateral cortex. The intraosseous distance is measured using the pin. The pin tip is then driven out the skin. A number 11 blade is used to slightly enlarge the pin site down through the iliotibial band to facilitate tying of a security knot later. The pin is used to pass a shell-link suture, such as a tiger link. The adjustable loop cortical suspensory femoral fixation is prepared as follows. Two number 2 high-strength sutures are looped through the two center holes of the button, with tails going distally along with the adjustable loop. These will be used for the internal brace. A number 2 tiger wire is placed through the adjustable loop to be used for counter traction. The adjustable loop is marked at the measured intraosseous distance. The leading fiber wire and the white tensioning sutures of the adjustable loop are shuttled through the femoral tunnel. Distal counter traction is provided using the tiger wire in the adjustable loop. The button is flipped against the femoral cortex after the intraosseous distance is reached. Next, the ACL grasping suture is linked to the adjustable loop. One limb of the ACL grasping suture is brought through the adjustable loop. With a switching stick placed to prevent a tight capture that would prevent normal sliding of the adjustable loop, the ACL grasping suture is tied to link it to the adjustable loop. The loop is shortened until most of the slack is taken out of the ACL grasping suture. The tibial shell-link suture is moved to the far anteromedial portal while ensuring no tissue bridge between it and the internal brace sutures. An arthrotomy of about 4 centimeters is made by proximally extending the far anteromedial portal. A half pipe is used to protect the sutures in the portal. The knee is dried. The 4 limbs of the 2 internal brace sutures are passed longitudinally through the BEAR implant and then shuttled down the tibial tunnel. 10 milliliters of fresh autologous blood is worked into the BEAR implant. The implant is pushed into the knee, guided by the internal brace sutures into the femoral notch. The sutures are then tied over a simple cortical button with the knee in full extension. The adjustable loop is then used to take all remaining slack out of the ACL grasping suture. For further security, the tensioning sutures of the adjustable loop are tied using a knot pusher.